All right, we're going to continue with the hyperthyroidism and hypothyroidism. I know I got cut off on that last recording a little bit. So assessment data to go on with the labs, we expect to see like either a normal or a low free T4. We expect to see that thyroid not functioning either subpar or just barely at par. So then we have to compare with the TSH. What is the pituitary gland telling the thyroid? So for them to have a hypothyroidism, that TSH has to be elevated. It has to be showing that that pituitary gland is saying, come on, thyroid, you have got to produce more. Come on, come on. So we expect to see a high TSH in either a low or normal free T4. Treatments, we're going to be primarily looking at doing some levothyroxine sodium, which is the hormone replacement therapy. It is small doses over weeks and weeks and weeks. We may need to do a subtotal thyroidectomy if there's dyspnea or dysphagia, like that goiter, or the thyroid is just taking up so much of that trachea again that they have to surgically fix that. Okay, Hashimoto thyroiditis. This is the most common cause of primary hypothyroidism. It is an autoimmune disorder, and so it's when the person's immune system is actually attacking the thyroid, so it can't produce the thyroid hormones it's supposed to for metabolic regulation. Assessments we're going to see the exact same assessments here as we do with other hypothyroidism. So the key is they're probably going to take a biopsy and see those cells being damaged, and that's how we'll know that this is Hashimoto. Typically, it's in women from 30 to 50. Goiter is going to be the main symptom of this. These women almost always have a goiter. Usually a family history of thyroid issues is seen, and that would be your at-risk population. All right. Myxedema, coma, this is a life-threatening emergency. This comes from usually some kind of a non-compliance with thyroid hormone therapy or trauma, infection, can be hypothermia, or using central nervous system depressants like narcotics or tranquilizers, and this is often found in women that have chronic hypothyroidism that is exacerbated or worse during the winter months. What do we see for assessment? Assessments, we're going to have seizures, lethargy, level of consciousness that goes to coma, hypothermia, because their metabolism isn't producing as much, respiratory and cardiovascular system shutdown, so bradycardia, bradykinin. Treatment. So finding the underlying cause to prevent coma and death is going to be paramount. So if it's because they're really cold from being outside, then we need to get them warmed up. If it's because of an infection, we need to figure out, if we can do antibiotics or something like that to fight this infection. If it's trauma, we might just have to start with thyroid hormone replacing therapy. We want to make sure that there's a patent airway, stabilize cardiac function the best we can, improve ventilation. Maybe they need an ambu bag or ventilator. Try to keep their body temperature up, and then we can do an IV thyroid hormone replacement therapy for these patients. I'm going to keep going here with altered nutrition. So the first thing I'm going to talk about is stomatitis. So stomatitis, this is an inflammation of the oral mucosa, so the lining of the mouth. At-risk population, people with cancer, doing cancer treatments, people with dental disease, people with AIDS, herpes simplex, people that have canker sores in their mouth. These can last weeks to years, usually less than 1 centimeter in diameter. This can also be due to fungal infections, like thrush. For assessment, whenever assessing the mouth, you guys should remember this from your physical assessment training, you have to wear gloves. So, if it's wet and not yours, don't touch it. Okay, we look for pain. So if we're doing an assessment and we, touch an area in their lip or something like that and they go, ow, we're assessing for pain, or can you tell me if that hurts kind of thing. If they're having difficulty eating, sometimes these sores are so bad they don't want to even eat or drink anything because it just hurts. Painful white patches with red bases is something we look for. Swollen oral mucosa, ulcerations, and clusters of painful lesions. Diagnostics, we got to figure out what's causing this. So oftentimes we're going to do a scraping of these. So the doctor's going to just either get like a cotton tipped applicator and get a sample that way, or he'll take like a scalpel and scrape at it, get some of those cells on a slide and under a microscope to see what it is that's growing or causing it. Cultures is also going to be if we don't see any fungus on the slide, we might start testing it for some bacteria. So we might see a culture and sensitivity ordered. Treatments, we got to hit this treatment two ways, trying to treat what's actually causing it and then treating the symptoms, because the symptoms can be pretty bad. So topical anesthetic and anti-inflammatory is going to help with those symptoms. So it provides very temporary relief, just enough to maybe eat or get to sleep. Things like Oragel, viscous lidocaine, Ambisol, and triamcinolone acetonide. Those are common anesthetic anti-inflammatory medications that we use in the mouth. If it's because of a fungal infection like thrush, then we typically see a topical antifungal that's ordered. Local, meaning, they're going to have to either swish or spit or swish and swallow. We talked about like the Witch's Brew and Magic Mouthwash and Zybel's last semester. So we typically see something like that again. The order will say something like swish for 2 minutes, and, depending on how far they go down, we don't usually like people to swallow this stuff because they can sometimes feel like they're not able to breathe because it just numbs everything so well. But if those sores are going back pretty far in the back in the pharynx, then we'll have them swallow it. But just lots of education, you're probably going to feel like you can't breathe. Clotrimazole is also an antifungal that's ordered, and then nystatin, which can be in ointment, a cream, and a mouthwash as well. Antivirals, if it's because of canker sores, so something like acyclovir can be ordered. All right, gastritis. So what is gastritis? That is inflammation of the stomach, more specifically the stomach lining. Etiology, something that causes the stomach lining to be irritated. It could be a disruption of the mucosal layer where the gastric juices reach the gastric tissues. These generally heal pretty quickly because it is such a vascular space. Okay, medications that cause irritation are things like aspirin, NSAIDs, ibuprofen being one of the top ones that can cause this, chemotherapy, and steroids. We also look at alcohol use, caffeine, and different food poisonings that can cause, stomach upset. You guys have heard of, people using spoiled food at restaurants or something like that, or they get contaminated with something and that causes food poisoning. Bacterial contamination or viral contamination. The norovirus, this is a fecal to oral route. This is a very contagious. This is usually when like the schools get hit really hard by something. It's typically the norovirus that is hit very hard because of how contagious it is and how long it's contagious for. Norovirus is usually contagious for like 2 to 4 weeks, even after the symptoms stop. So complications with gastritis, this may lead to perforation. So like if this weakened area in the mucosal lining gets too bad, it can actually go through that entire lining where stomach contents are actually leaking into the peritoneal cavity. If that happens, then we're at risk for peritonitis, which is a life-threatening, very painful condition. And then hemorrhage, we worry about hemorrhage because like I said, it's very vascular. So if we have something cutting into blood supply, we're going to expect quite a bit of bleeding. If this person has a history of stomach surgeries or abdominal surgeries, something that we look for would be maybe decreased perfusion to a particular area in the stomach. Sometimes that can lead to these issues as well. So assessment. These people that have chronic issues with gastritis, I have a friend that, man, through college years, he couldn't eat a thing. Like he he knew his stomach was going to be just so upset after he ate anything that he hardly ate. And so he got very, very thin. It was kind of scary for a while until he finally figured out some medications that were working for him and allowed these ulcerations to heal. But anorexia, just because they, don't want to eat, nausea and vomiting, abdominal pain or discomfort, hemoptysis, which is vomiting up blood, melena, which is having black tarry stools, right? That's an upper GI bleed if they're having the black tarry stools. Anemia, just because they're bleeding, right, internally. And fatigue, well, again, because of the anemia and the bleeding. Diagnostics, we're going to look at hemoglobin, electrolyte status, a stool specimen to see if there's any blood in that or anything else, ovum, parasites, white blood cells, and see if maybe a culture shows anything. Going to look at gastric pH, and then possibly doing an endoscopy where they put a camera down the throat and just see what is forming. Okay, treatments. So medications, whoops, I'm scrolling the wrong thing and then I lost it. Sorry, guys. Antiemetics are going to be used if we have a lot of nausea that's going on with this. Ondansetron, which is Zofran, promethazine, which is Phenergan. Those are two of the top ones. That Phenergan, though, has a tendency to make people very tired. Antacids, such as Tums or Rolaids, can be effective, but remember, we don't want to use them too much, otherwise we can put a person into metabolic alkalosis. PPIs, proton pump inhibitors. Those would be your ZOLEs, omeprazole, esomeprazole, pantoprazole, lansoprazole. H2 receptor antagonists, we talked about this with the allergic reactions, right? That's a histamine too. So famotidine and ranitidine are those two. Sucralfate, this one I know we've given lots of in the hospital. This has also been a godsend for my grandmother as well. This medication needs to be taken before meals and before bed, and it coats the lining of the stomach so that they can actually eat and not have an upset stomach because of it. So very effective in ulcer treatment. Fluid and electrolyte management, so rehydrating patients with severe vomiting and diarrhea. Oral rehydration is best. I had a phone call once from a patient when I was triaging that said, I think I'm dehydrated. And I said, okay, can you tell me more about that? And she's like, yeah, I got really drunk over the weekend and I don't think I drank any water and now I just have a headache. And I said, have you tried drinking any water? No, I just think I need to come in and be seen for dehydration. So, I did convince her, why don't you try drinking? Because oral rehydration is best. It's better than IV hydration if we can do it. Drink a couple glasses of water and call me back if you don't have any improvement. Well, she called back and she was improving, so she did not come in. So, but anyway, progressing slowly from clear liquids to just full liquid, and then maybe introducing some bland solids in there like toast or crackers, and then, progressing to regular diet from there. Antitoxin, if gastritis is caused by a toxin, like a poison or something, with those that they're typically too dangerous to vomit and can damage the esophagus, things that are very corrosive. We talked about that with the poisonings. So lots of education there.